want to welcome you to Texas Biomed's Global Health Symposium, the inaugural event. We have the illustrious Dr. Schlesinger joining us. Oh, second event. And it was virtual, totally virtual in the past, right? So totally virtual. So now we've got a hybrid. My name is Suhail Arastu. I work in advancement for musical bridges around the world, but I have a background and connection to San Antonio and a long history of Texas Biomed going back to my high school days. And though I studied neuroscience out west at the University of California, Berkeley, I came back to San Antonio after a decade away and have served as 2 terms as a trustee of the Mind Science Foundation, a sister organization of Texas Biomed, and serve on the Founders Council for the support of Texas Biomed here currently. I'd like to begin by just introducing the panelists we've got. We've got one with us live and we've got 2 joining us virtually, and then I'll tell you more about them before they give their statement, and we'll have a little bit of time for Q&A as we progress through the session. So we are looking at global health institutions, and as we address critical gaps in setting priorities through 2050, how do we manage global health in a time of worldwide change? So we'll start with our online panelists. We have Dr. Wondwossen Gebreyes, the Hazel C. Youngberg Distinguished Professor and Executive Director of Global One Health Initiative at The Ohio State University. Welcome, Dr. Gebreyes. We have Adrienne Parrish Fuentes, who is the Director of Global Health Policy for Thermo Fisher Scientific, as well as Dr. Ed Kelley, the head of ApiJet Global Initiative, and also serves as their Global Health Officer while heading their Global Health Division. So welcome, Dr. Kelley. And here, Dr. Chidi Achebe, who is currently the chairman and CEO of the African Integrated Development Enterprise. And that is a Boston-based organization dedicated to development on the African continent. They work to bring together international companies and expertise to address infrastructure and needs on the African continent. And he served as the president and CEO of Harvard Street Neighborhood Health, as well as the medical director of Whittier Street Health, and as assistant professor at Tufts University at their School of Medicine, all in Boston. He earned his medical doctorate at Dartmouth and his MBA from Yale, his master's in public health from the Harvard School of Public Health, and he's a strong advocate for healthcare equality. And so that's what we're going to hear a little bit about today. We're looking at global health, but oftentimes Africa's left out of the conversation. And so I think we're going to get an overview, looking at some case studies as well as examples and then opportunities as we look at policy investment. So we'll turn it over to you, Dr. Achebe. Thank you for joining us.
I need help turning this on. All right, great. Well, good afternoon, everyone. I'm going to stand up because I don't like sitting down. The didactic style works, but I find it's boring. So I like to kind of mingle in the crowd. So I'm going to talk about, when we talk about global gaps, Africa, like he said, is often forgotten, right? So it's like the stepchild that needs to be brought in. And we need to put a bow tie on this stepchild. So that's my focus. Next slide, please. I'm going to begin with a background on Africa, and then we'll talk about some of those challenges. We're going to talk about how we're going to address some of the gaps in infrastructure, manpower. I'm going to look at 2 of the most populous countries, Nigeria and Ethiopia. All the statistics here is the Ethiopia before the war, right? Which was on a trajectory of greatness, and I hope they'll get there again. We'll then quickly talk about healthcare trends and investor opportunities, and then some policy that we should be aware of. Next slide, please. We all know that Africa is the 2nd most populous continent in the world after Asia, 1.37 billion people. It's the most concentrated in terms of genetic diversity in the planet. Everybody in this room, whether you like it or not, is an African, okay? So that's something that you need to understand. Next slide, please. By the end of this century, 1 of every 2 children will be born on that continent. That's an increase of 170 million to 750 million in just the next 8 years. The UN's Children's Agency, of course, thinks it's due to increasing fertility rates, a rising number of women of reproductive age, and mortality. Next slide, please. So in terms of addressing what's coming, either we do the right thing and we'll take care of it and Africa will be booming and we'll all be happy, or we're headed for a catastrophe. And I don't mince words when I'm saying this. Africa needs between 25 and $30 billion of investment in just healthcare assets alone over the next 10 years. This should be pumped into sectors for physical capacity building, developing hospitals, clinics, and pharmaceutical distribution warehouses. The most populous nation on that continent is Nigeria, 200 million people. That country alone needs an additional 100,000 beds. For the rest of the continent, is between 550 and 650,000 beds required during the same time. Next slide, please. This is even more dire. The UN estimates that Africa needs 11 million more doctors, nurses, and healthcare teachers just by 2030. We're not going to get there, so don't stress out, right? We'll talk about what we should do since we're not getting there. Sub-Saharan Africa needs an effective and efficient physician and nursing education systems, right? Not just on individual, regional, but on continental and global levels. We need to find a way to collaborate with institutions like yourself and develop the physician and education bodies that are in existence and improve their quality, quantity, and just do a better job in educating the people that are required for the improvements that we're talking about. Next slide, please. Now, COVID-19 just brought to the fore the importance of telemedicine, and that the role of telemedicine in Africa. You can imagine, as important as it was here, you can augment that 1,000-fold, and you see some of the opportunities. I was just talking to this lovely gentleman a few years ago about cell phone revolution in Africa. That's a giant 100-year leap that most people take for granted. I'll use Nigeria as a case study. 20 years ago, there were 5 million cell phones. Today, there are 110 million in Nigeria alone. That gives you the opportunity to bring about a lot of the training and infrastructure that would cost billions and utilize technologies that are already disrupting that environment and use them efficiently and effectively. So there's a lot going on in Africa, and we need to be able to use these opportunities to partner, collaborate with global institutions, and find smart ways that are not necessarily more expensive, but just smarter ways to get these final results down. Next slide, please. I'm going to do a quick country comparative analysis. The goal here is to tell you just how a country like Ethiopia wasn't spending a ton of money and doing so much incredible work, and yet a country like Nigeria, which is the largest economy, was doing so poorly. So it's not about just money. It's how you're organizing the money you are allocating to healthcare. So Nigeria on one side, the largest, Nigeria is underperforming. Nigeria should be a $1 trillion economy today with all its bad press. It's a huge economy. It's a fact. It's the China of Africa. And look at Ethiopia, 200 million for Nigeria, 115 per capita income. But then look at what they're doing in terms of government expenditure as a percentage of budget. Ethiopia is spending 3 times what Nigeria is spending, even though Nigeria is so much wealthier. And then when you look at that per capita, the goal for Ethiopia was $100 per person, right? And so, next slide, we'll kind of begin to, I'm going to spend a little more time very soon. So let's just talk about some of the challenges in Nigeria. Overall lack of quality of the integrated healthcare system, very few state-run facilities, overall they're poor to fair in terms of quality, whether it's equipment, facilities, or healthcare services. A lot of things hamper the healthcare system in Nigeria, lack of coordination and clarity between different levels of government. This is a major impediment to quality, so you get different quality indices depending on where you go in the system to seek service. There's a fragmentation of those services and just a general dearth of resources. Many ancient scourges that should not be in existence I didn't put down leprosy, but just stuff that you shouldn't be hearing about. It's all biblical. I'm not sure why we're talking about it in 2021, but they still exist in parts of that country. Next slide, please. I'm just going to slow down a bit. Bear with me. This is busy, but this is important. So what has Ethiopia done that's important? What have they achieved? They've ramped up their efforts to reach key health targets by 2030. Child mortality has dropped by nearly a third. Okay, this is prior to the war. I don't want anybody coming to me and say, wait a minute, the latest numbers say, I'm talking about what they did just prior to the war. They dropped child mortality that we can achieve in this country, so that you understand how huge this is. They dropped this by a third in 7 years. They recruited 35,000 healthcare workers and pushed them into the rural areas. They recruited a number of development partners to strengthen what they're doing. Together, the international as well as local funding of the healthcare system in Ethiopia has almost tripled. And if you look at what they're doing over a 5-year strategic strategy, they're going to go from a 6-tier healthcare system, which they inherited. Well, they never were colonized, but which they kind of copied from Europe, to one that they have adapted to their own needs. That's a 4-tier system. They increased access from 50 to almost 65%. The quality was improved. They strengthened management of healthcare and federal and regional levels. And they are encouraging participation of the private sector, which has been a very big key to their success. Next slide. So what are some of the trends? There's going to be exponential private sector growth. My company, our goal is very ambitious, to raise $1 billion in 10 years. We believe we can get there. Now, Nigerians, so that you know, spend $1 billion on medical tourism every single year. I have a king out of one of the cities, which I won't call because this is being beamed internationally. He comes every year to see me with a retinue of 25 people. Every year. Cash. Right? These are multimillionaires, means nothing. We can't, this is not sustainable. The continent needs to plow those dollars into the continent and keep people there with high quality services. So you're going to expect large investments in infrastructure. Everywhere I look these days, because I'm in the field, Senegal, I'm involved with a partner who's doing something there, Kenya, Uganda, wherever you look, there's exponential growth in private sector funding of healthcare services. Now, this trend will continue due to the fundamentals that drive demand, population growth, life expectancy, growing disease burdens, patient demand for treatment. The 4 biggest countries that people go to: India, Great Britain, the USA, Dubai, or UAE. Next slide, please. So I'm going to just conclude. One of Akudo's and my professors, David Bloom of the Harvard School of Public Health, they stress that the overall economic returns on investment in health appear large. We all know what immunization has done and can do and will do. Is the best example we have. But better health improves well-being through lower rates, fertility rates. And Nigeria is expected to be 800 million people by 2100. We can't, no, we can't do that. Right? It's unsustainable. We need to find a way to improve the healthcare outcomes and services to be able to empower women. If you want anything to succeed, you start with the women, you empower them, and you will get to your targets. Forget the guys, I'm sorry. Just focus on the women, and you'll get where you need to. So that's very important. And lastly, a large number of diverse interventions can induce and support improvements, as we know, in population health, and that is our goal at AIDE PBC. So that's my contribution. Thank you.
And thank you, Dr. Achebe, for that.
Slip in here.
Okay. And we see that the problems are manifold, as are the opportunities for investment, for research, for innovation in the African continent with the burgeoning population. And we move now to look at more of those challenges as we turn to our virtual panel. We have Dr. Wondwossen Gebreyes, who I mentioned is the Director of Global Health One. He's led several programs funded from the NIH, the CDC, USAID, as well as the Gates Foundation. He serves in international advisory capacities for various government entities, including Brazil CAPES, the Ethiopian Ministry of Science and Higher Education, as well as review panels for Austria, Poland, Qatar, among many others. Dr. Gebreyes leads a global capacity building initiative addressing international issues at the interface of humans, animals, plants, as well as the environment. He's a recipient of several awards in leadership and internationalization, looking at different models and education. So we're so honored to have you here today, joining us. And tell us a little bit about the unpreparedness and what we've learned from COVID-19, and then your role at Global Health One, and how we can address some of these silos that exist.
Right. Thank you so much. Let me start by really acknowledging the Texas Biomed Group colleagues. First of all, good morning, good afternoon, good evening, wherever you might be. I am sending you this message from Ohio State Global One Health, Eastern Africa location here in Addis Ababa, Ethiopia. It's warmer than Ohio, but for sure cooler than San Antonio, Texas, I think. Congratulations, my longtime colleague, Larry, Dr. Larry Schlesinger, and all the wonderful team members at Texas Biomed in San Antonio community. This symposium cannot come at any better time than today, I believe. For sure, as we heard since the keynote speaker, Dr. Monroe, and all the discussions, really global health and sustainability, our planet, in my opinion, is being challenged constantly. I think we all agree on that, constant challenge. Dr. Achebe addressed the Africa part, but just generally our planet we are, I think, about 7.6 billion of us on this planet today. And according to the UNICEF, every day, 370,000 babies are born on this planet. I quickly checked earlier today what's the Texas population here, close to 30 million, right? So, imagine, the proportion of this 370,000, an island size of, babies born each year, each day, just in few, months, it reaches to the population of Ohio or Texas or, a large number. What does that mean? Of course, the land mass of our planet remains constant. So there is this constant pressure, rapidly increasing urbanization. Today, about 55% of us live in big cities, but heading to 68 to 70%, I think, by 2050. Increasing protein demand from animals, that's for human consumption, deforestation, that results in climate change, encroachment of us, humans, Homo sapiens, into wildlife and other territories. We're getting close to each other. So that has, constant daily pressure on the global health of our community. So really great on this conference or on this symposium addressing leadership, innovation, community, and wonderful, lots of keywords, partnership, and others are mentioned. I just want to make a few points based on the question I was asked. As a result of this complex, interdependent, and interconnected planet, I think we face critical challenges in terms of global health. So the low-hanging fruit and what we see on this pandemic is emerging infectious diseases. Of course, a key factor of that is the spillover from animals, domestic as well as wild, what we call zoonotic diseases. These are responsible for more than 2/3 of the emerging infectious diseases in humans. When you add foodborne, waterborne, vector-borne diseases that are transmissible between humans, animals, and the environment, plants involved, the burden is so huge, and that's increasing constantly. But I believe we're not giving it enough attention to be prepared and prevent catastrophic large epidemics or pandemics. As you know, Ebola has a connection with wild, fruit bats, or SARS-CoV-2 as you heard it repeatedly from wet markets and wildlife or some domestic animals. So the burden, this interconnectivity adds to the burden of the global health that we should really keep in mind. Other complex issues such as antimicrobial resistance, many of us and many of you, I'm sure in the room, are working on, is really a big, complex global crisis. It's estimated to cost 10 million lives per year by 2050, and a cumulative burden cost estimated with a highly reputable data a few years ago that it will reach to $10 trillion and disproportionately impacting developing countries, particularly Sub-Saharan Africa and Asia, but all of us across the planet. I think other factors I mentioned, such as climate change, is again exacerbating the burden in biological hazards. As you know, vector-borne diseases, their ecosystem and ecological scenario is changing, as well as other chemical hazards or air pollution, water pollution, other issues, also adding the burden in terms of non-communicable diseases, including cancer. I recently read a report from World Economic Forum, the global risks. The cost to our planet, to all of us, due to non-communicable diseases has reached in over 10 years, they estimated it $47 trillion, or that means about 5 trillion per year, due to treatment cost as well as loss of productivity. So imagine if we have a way to utilize large amount of resources to prevent, prepare, and make our planet a better place. What we learn from the global dynamics in terms of global problems are more and more complex. And of course, besides the lives, there is a number of other ripple effects that we heard earlier today during the panel discussion. So what's next for global as institutions, and what would be the solution? So unfortunately, as we all witnessed from the current pandemic, I think all of us remain severely very ill prepared or severely underprepared to address these vulnerabilities. Often we refer to Africa or Asia as well as other places, low to middle income countries, but we saw the burden in the United States also extremely severe due to COVID-19. I think we are all in the same part, and we should address. I like the build back, not better, build back equal scenarios. That would be a wonderful thing to do for all of us. I think the challenge we saw is, and why the gap that I mentioned, the interface of human health, animals, environment, what we call One Health. Our systems, organization systems are highly structured in a siloed way. That is a critical problem we all should address. We talk about collaboration, we talk about partnership with others, but often we boil back down to our silos, our comfort zone. I think we need to go beyond our comfort zone and really change our individual mentality as well as our organizational thinking. While the administrative silos could still exist, we can make every effort to be collaborative. So for the question you asked, I think in terms of the lessons we learned and what we can do across disciplines, there are a few things to think of. One, I think really a true transdisciplinary paradigm. These complex issues bring in a convergence model. I think National Science Foundation back in 2014 recommended this convergence approach, how effectively we can address complex but unsolved issues. So the One Health, the paradigm you hear more and more, and I'm sure you'll hear it more post-COVID-19, really embraces that convergence model. The global One Health approach that we are using, it recognizes that interdependence of human, animal, plants, environmental health, we depend into each other. And we advocate for a holistic approach addressing issues at the interface, like AMR, a clear interface between environment, human, animals, or zoonotic diseases, or many other issues. So if we work at the interface effectively, that will lead to improved health outcomes, enhanced livelihoods, and build or strengthen resilience in our system. unfortunately, we tend to neglect the prevention preparedness part within One Health paradigm. Then we end up getting large epidemics or pandemics. Then it will cost us thousands of times in terms of mitigating it, as COVID already costing us, at least a recent estimate I saw, minimum 9 trillion, perhaps much more than that. Secondly, I think we need to embrace key framework. Earlier, I think Larry and other colleagues raised in terms of trust and confidence. Is there a framework that's working across different sectors, countries, globally? What is existing there? One, I think a good example I can mention, and using the One as framework, but a global health security agenda. Global security agenda, the US government, multiple European LMICs are participating in this agenda. It has 11 key priority issues, including zoonosis, AMR, but laboratory capacity building, workforce development, really strengthened international health regulation. Many other issues are addressed in that, and many countries are participating in that. We are implementing partner with the US government, particularly CDC, and we're happy to say, I'm very happy to say, we've done great work to make impact in different parts of the world, including particularly where I am at here in Ethiopia. So besides the GHS agenda, broadly thinking, the third thing I want to emphasize, it's been mentioned a little bit, is really we need to focus building and strengthening resilient health systems through capacity building. Capacity building, that's workforce development capacity, laboratory capacity, field surveillance capacity, and really enabling effective leadership and communication systems. Dr. Monroe, Judy Monroe mentioned earlier as our keynote speaker, the systems thinking. It's been repeated a few times. We really have to work in systems mode to really have exponential impact. So with this capacity building, to give you a few list examples from our Ohio State Global One Health Initiative, our vision is advancing healthy and thriving global community through building capable institutional systems and professionals. So one of the countries we use, and thank you, Dr. Achebe gave you a good highlight already, is Ethiopia. We have been working for the last more than 10 years in Ethiopia, as well as in other countries, Kenya, Brazil, Thailand, a few other countries, but I will give you a few examples of in Ethiopia and what we achieved in terms of capacity building. We helped the nation set up a national One Health system, bringing together 17 sectoral partners who traditionally do not collaborate to each other. These are research, academic, regulatory bodies, and policy makers, including the legislative body of the nation. So that is, to get them to used to, address across boundaries, really bridge across their existing silos. We helped them establish a system for surveillance, national system, mass vaccination using a classical disease such as rabies. Rabies is an old disease. We use it as a model to establish this effective national One Health system. But at the same time, we make grassroots impact because rabies kills more than 1,500, particularly children in the country. We helped train a large number of cadres, small targeted trainings, I think more than 4,100 as of last summer. So summer institutes that has been running for the last 10 years. But also we trained about 28 PhD fellows through multiple programs and projects. I thank NIH Fogarty International Center, Bill and Melinda Gates Foundation, National Cancer Institute, and many others that helped us train this cadre of PhD fellows. But the need is so huge. What we are trying to do is very minimal, but some of these former PhD trainees who are now, some of them are associate professors and so on, are the ones leading SARS-CoV-2 diagnostics that we trained them in molecular epidemiology, genomics, and so on. We helped with more than 700 healthcare centers and hospitals adopted a new treatment regime on TB, HIV. That was a grant funded through the USAID, but really with the goal of also building capacity of clinical trial capacities. That's been mentioned earlier. but I really would like to mention that now 700 plus healthcare centers adopt that. We help standardize clinical specimen collection, diagnostic stewardship. This is to address antimicrobial resistance issue in nosocomial and community programs as part of our CDC Global Health Security Program. And one last example is on COVID-19. Early on, we launched a non-pharmaceutical intervention or public health social measures in the country. We conducted a large number of serosurveillance, and very thankful, I don't know if Dr. Monroe is here, but very thankful for CDC Foundation. We work with CDC Foundation grant as well as the Resolve to Save Lives on the COVID-19. So I can keep listing many examples, but I just want to emphasize that capacity building, capacity strengthening is highly needed. More needed in LMIC, yes, but highly needed also within us, whether it's Texas, Ohio, or in the United States, or be it Europe, because the world is severely behind considering the complexity of the issues we are addressing. The fourth last point has been mentioned a bit today is to achieve all of these, we need resources, particularly allocating significant financial resources are critical to address these complex global challenges. And this is not a cost like an expenditure or wastage. These are true investments. While I greatly appreciate a number of partners we work with, NIH, Gates Foundation, and many others I mentioned, I think upfront investment on global health is a really wise decision that will save us a cost in terms of human lives as well as productivity loss. I am aware that many of you may have read it. President Biden's current budget proposal to Congress has a request for $81.7 billion over 5 years towards prevention and preparedness of future pandemics. Some people may think that's a lot of money, but it is not. If you think of just COVID-19 pandemic, it already costed us, in terms of $10 trillion. So it will be really wise investment preventing future pandemics. So in summary, I think let's accelerate collaborative partnership and break silos. I think we need to work in synergy. So thank you, Texas Biomed. I think we need 80 years and one voice. I think we need to have one unified voice to address together. Thank you so much.
And thank you, Dr. Gebreyes. One voice, global, one health, and the Earth is a breathing planet. It's an organism, and we're part of that. And sometimes it's a disservice to have these silos so disconnected. My family comes from India. My mother's father was a homeopath, Ayurvedic medicine, holistic approach, and sometimes in the West, we have a reductionist approach. But we're looking at the opportunity to get all of these models, to get these partnerships between all organisms and see how they interact. And so thank you for the work that you do. And we're going to get back to you with some questions. But first, we're going to move to our final virtual panelist. We have Dr. Ed Kelley, who I mentioned leads the global initiatives and is the Chief Global Health Officer at ApiJet, and as well as ApiLabs, their global health division. He recently left his position at the World Health Organization's as the Director of Integrated Health Services, where he helped lead the organization's COVID-19 response, creating WHO's first public-private partner collaboration and working directly with the pharmaceutical and medical device industry to improve health services and patient safety. In addition, he led the organization's work for global strategy, their strategy on digital health. And prior to his work at the World Health Organization, he served as a director of the U.S. National Healthcare Reports at the U.S. Department of Health and Human Services, reporting directly to his agency director and the secretary. So welcome, Dr. Kelley. So what have we learned and what's next?
Thank you so much, Suhail, and a big thanks to Texas, just to echo Wondwossen's point there, thanks to Texas Biomed, to Larry and Akudo and Susanna and the team who shepherded all this effort in a, I would argue, a not quite yet post-COVID world, but and a thanks to yourselves and the other panelists for being willing to welcome a couple of us from Ethiopia, and I'm coming to you from Geneva, Switzerland, so a bit later in the day. But in terms of what's coming next, I think this panel really is such an interesting one in terms of laying out a number of issues, four issues actually: gaps, priorities, trends, and movements. And to build and maybe pick up where one had left off on that, a few maybe trends and priorities just for a moment. If we're looking at this question that was just raised about investment in health, the world spends upwards of 8 to nearly 9 trillion globally on healthcare. Only about 10% of that probably goes for primary healthcare, which is the most cost-effective care, as a range of studies that have looked at that. Our own WHO's report in 2017 laid that out. Only about 0.3% of preventive healthcare. And if you look at what the independent panel on pandemic preparedness came out with a year ago, estimating only about $375 million was spent on international aid on outbreak preparedness. But really what was needed was somewhere in the range of 5 to 10 billion per annum. And as was just said, that sounds like a lot of money, but that's only, as we talked about earlier, about 0.1% of what we spend on healthcare globally, and only about 1% of what COVID will cost the world's economy. So the trend and our mindset for decades has been to under-prepare and then to rush in terms of preparedness, and then to rush the fire engines out there when the emergency is happening. I'll come to the impact of more recent outbreaks in terms of the movements, but over these past decades, the questions of strengthening health systems and building kind of more comprehensive approaches, both at a national level, at a global level in terms of development, versus reacting to health emergencies and being able to plan and deliver for those were seen as somehow, in our sense, everything in this world is a zero-sum game, apparently. Those were seen as somehow mutually exclusive, and especially in terms of scarce aid dollars, that you either invested in infectious diseases and epidemics, or you cared about health systems, but the two really didn't come together. If you go all the way back to 1978, which, I guess myself and a few people in the room can remember a bit, we committed with the declaration of Alma-Ata in then USSR, now Kazakhstan, that healthcare was not something that was reserved for those who could pay for it, that there was an access and a primary healthcare for all was the call that was made. That evolved over several decades as we went through different development agendas driven by the United Nations, from the Millennium Development Goals to the Sustainable Development Goals, where we most recently, as a global community, committed to the idea of universal health coverage, that the idea that access to health services without having to pay catastrophic costs and be in financial ruin was a basic concept and a basic right for people. And the wording of that is very important. We also recommitted to that back in 2018 with the Declaration of Astana. That was a conference hosted by the government of Kazakhstan, WHO, and UNICEF. I was very involved in that. And there was a strong push and idea that returning to the basic idea of primary healthcare, a core set of services, and that included preparing for outbreaks, because, of course, the first place that an Ebola case, a SARS case, a Zika case, a COVID case comes is to their primary healthcare center, and you need to be able to recognize those diseases, send them upstream. All of that was seen as very strong. And then, of course, COVID came. So after each of the recent outbreaks that we have seen, if you take 2003 with the SARS outbreak, 2014, I was very involved in the West Africa Ebola outbreak. You then had Zika, the DRC Ebola. There has always been a reaction of, well, we need a better set of tools on pandemic preparedness. And each time somehow we have not either sustained the attention or come up with the right set of metrics behind them. So if we look, maybe I take just a minute before I wrap up here to talk about maybe some of the gaps and priorities that we might take from this particular slice. Chidi did a great job of talking about the broader picture and using a few examples. But if you take the slice of pandemics and health systems strengthening and where that puts us in terms of preparing for a potential post-COVID world, my own role at WHO was during the COVID outbreak was in setting up for the first time a pillar within WHO's emergency response plan that was devoted to maintaining essential health services. And it might seem like that's a strange thing, but actually in very recent past, the idea of that it's the job of the emergency response team to also worry about keeping essential services running, that was not a given, actually. And we had, at the very beginning of the outbreak, people will remember, and we're still living with the consequences, massive shutdown of services. Many programs have not recovered, particularly the tuberculosis program, HIV treatment. Other programs have been a bit more resilient and been able to come back, like malaria. But we have, last year, the highest number of unvaccinated children that we've had in a decade. And this is clearly one of the consequences of the gaps in our thinking, that we dropped essential services and had to move on the response side. Clearly, there's a need to consider the focus that we've had at the global level. There was, if people remember, the access to COVID tools, the ACT Accelerator was stood up as a coalition of organizations working in global health to ensure that access to vaccines, to therapeutics, and to diagnostics would be something that was not the privilege of countries who had deep pockets and treasuries, but of all countries. The 10th ACT Accelerator Facilitation Council meeting was just held last week. I think most of us involved when we started this thought we might have 2 or 3 possibly. So just the fact that the ACT still has to exist is a testament to perhaps that we haven't, there is an opportunity for improvement. And the fact that at the moment only 15% of low-income country populations have gotten 1 dose of COVID vaccine versus the vaccination rates in the rest of the global north is also a second testament. And I think finally this point that we need to be able to walk and talk at the same time. We need to be able to respond to COVID and keep our response going and routine services running, as well as be able to flex for other emergencies such as Ukraine, such as what's happening in Tigray and Ethiopia and Yemen, South Sudan, et cetera. So, if you look at where the crunch has been hit the hardest, you only need, I work closely with colleagues in Zambia, for instance. It's a population of a little over 18 million. And many sources reporting that many doctors and nurses have been infected with COVID, have had to cover for colleagues who are on sick leave. But at the same time, in this past year at least, you had the majority of the health workforce there who had not had paid leave in 3 years. So the idea that we are going to be able to pile an emergency response on the backs of the health workforce we have, with the biggest immunization campaign we've ever run, and not expect some breakdown to occur, much less, even discounting the COVID cases within that population. is very, very wishful thinking. The second example I would use is if you just take the question, which I work on now quite a bit, which is on the delivery of vaccines, on new designs for syringes, single-dose pre-filled syringes, et cetera. The issue that WHO and UNICEF flagged back in end of November, that we were headed towards a major gap in syringe availability, is one of those basic head scratchers that you just wonder about, that we spent a lot of time worrying about vaccine doses and access to vaccine doses. It was an important issue, but at the same time, we spent almost no funding globally in comparison to the funding on vaccines and bulk vaccines, on the health workers that were going to be needed to deliver those, and on syringes, for instance. And if you take Nepal, despite having 12 million vaccine doses in the country, this was a month and a half ago, the central stockpile only had about 10,000 syringes. This is a story in the New York Times. So that's only one syringe for every 1,200 doses of vaccine. And for those of you like me who've worked in injection safety for many years, that is a recipe for syringe reuse, for spreading of diseases like hepatitis, HIV, and others. So I think the central lesson I would sort of take from this, given the history that we've had, is that it's time for, again, a call for a new synergy around, as Wondwossen said, resilient health systems that are able to account with the same thinking, the same mindset, the same budget, the responding to health emergencies, but also providing the core primary healthcare services that they need. And to deliver on those responses, you are going to need new partnerships to do so. It's quite clear that governments responding on their own during COVID would have never been able to come to the point where we are in terms of vaccine availability. At the same time, private sector on its own would have never been able to fund and deliver that. And academia being able to pull those two together, there's clearly a need for a new partnership model that span academic and private sector institutions, that draw on the latest tools and science from developed countries, but really need to be led by institutions from the global south. That is one of the, I guess, positive messages in my mind that's come out, that the way forward in terms of preparation is that local production, local manufacturing, both for vaccines, but also for fill finish and other essential steps in the supply chain need to be done. And our team at ApiJet is focused on solving delivery problems. And I think that's my last point, that we need to have a delivery mindset. We had the magical thinking that if we created vaccines, they would somehow, I guess, fly into people's arms, to the point where you even had some large Northern Hemisphere countries that'll remain nameless, donating doses for use in countries, but not also donating syringes, which is actually the WHO and UNICEF policy on this. So these kinds of partnerships and that delivery mindset is really going to take some is really going to have to be the focus of our thinking if we're going to respond to challenges like the G20's 100-day scenario for moving from discovering a disease to having a vaccine in arms in the next outbreak. We'll never get there without the partnerships that I talked about, and we'll have to have that delivery mindset to do it. So I'll end with that and pass it back to you, Suhail, and a big thank you to you and the other panelists for inviting me.
And thank you, Dr. Kelley, for taking the time to join us. It's almost like a comparison between preventative versus reactive healthcare when you talk about global preparedness for disaster relief. I mean, we've had opportunity to learn so much, and it seems to be a lot less costly, both in human life and in financial resources, when you take on that kind of preparedness. Here in San Antonio, for those that live here, winter before last, we had what we called snowvid, or the snowpocalypse, where we learned that our energy system was not up to par. And, you know, what does it take to prevent that, and all of the humanitarian crisis that took place as a result. And here we have, in a generation with technology, as we try to bridge that digital divide, an opportunity to share best practices from the global north. Of course, the problem sets are very different in places like sub-Saharan Africa. The tropics are different from Arctic medicine, but we certainly can share those. So we want to look, as we begin to kind of close this session, the outcomes, the solutions, the potential, but also hear from you, the audience, as well as our virtual audience. And so I know we have a couple questions that may be coming in. And while those begin to scroll in, we'll take audience questions from you guys, and we've got one here in the back.
I want to thank all the presenters. My name is Greg. I am a researcher in women's health, and I was particularly moved by Dr. Achebe's presentation. He touched a nerve, particularly when he talked about women's health, and also talking about some of the statistics from Nigeria. Well, I'll just give a brief insight into my question before I finally ask it. I use my spare time, part of my vacation, to go to very remote countries to do medical outreach. And one of those days, I was working in a place that was about half the size of San Antonio, no exaggeration, and there was no single health center. And I met a woman who was pregnant for her 21st child, 38 years old. I kept her a record in one of my videos. And I asked her, 21st child, 38 years old, 12 of those children are alive. And I asked her, she was like, third trimester. And I said, when are you going to stop this? Through an interpreter. And she said, I can't stop because I'm not sure if the ones I have will survive. So she'll be pregnant for 21 times, 38 years, 10 of those children dead under 5 years. So these are some of the stark reality that confronts us in terms of fertility control. I was trying to preach so much to her about fertility regulation and all of that. But when she asked me that question, through the interpreter, you want me to stop? Are you sure these ones I have will survive? I've already lost 10. I had no answer for her. So these are some of the realities that we really face. So the issue of health inequality, really strikes a chord with me. It's deeper than we think when you go to some of those remote regions. There's no health facility in those places. And these are the questions. The children are not surviving. You're asking them to regulate. They're not going to stop because they're not sure whether those children will survive. And really, the aspect of telemedicine, I really started seeing the reality of it because, I came to the States last year, so I've practiced that research all my life in the country. But over the past few years, my wife and I, we were worried about access to healthcare. So we set up a website called pregnancynigeria.com. And we are shocked at the impact it's making. So right here, I'm here in the US. I have over 5,000 patients who call me for things as basic as, doctor, I'm bleeding. Should I go to the hospital? I say, yes, that's an emergency. I knew somebody who I asked 2 questions, realized that she had ectopic pregnancy. By the time she got to the hospital, she was already unconscious. So I think I was so excited about Dr. Achebe's presentation. I think that telemedicine could really make a big difference in this. So yeah, away from my continent, touching the lives of over 5,000 patients online with basic things. Many of those small villages, they have small phones. And just a single question could make a big difference, in the lives of those people. Then also the aspect of synergy on health. But one of the things I did before I came here, I was leading the response of the Institute of Medical Research to response to COVID-19. As of 2020, middle of 2020, when we did our serorepeat study, I was one of the principal investigators for that study, we realized that close to 40% of our people were already exposed. So if you put that in perspective, this is 2022, so we're looking at 80%. So these are some of the data we need to have so that we understand that one cap does not fit all. Yes. We need to understand the local dynamics that work in community when we are sending support to them. We have to find out what they really need. I'm happy somebody mentioned about 10 million doses of injections, no syringe. Do you need to repackage those syringe for them inside injection before you send it to them? These are things we need to think about. I know that we're almost eradicating cervical cancer in the northern hemisphere, but as I speak to you, many of our women don't even know anything about HPV vaccine. A lot of women still die of cervical cancer. How do you bridge this synergy? This is the questions I have for the panel. We've talked about this for years and years, but the gaps are still there. Are we really doing enough, or we're going to have this conference again, we go back home and nothing is done? How do we really put the boots on the ground? I think I'll stop at this point.
Okay, very quickly. Well, thank you for that observation. I think that you have to meet the people where they are. You have to empower women. I'm a very big, first of all, I'm a son of a professor, right? My mom kind of drilled a hole in my brain and poured all this stuff about empowerment of women, right? But in all the studies, and everybody who's a scientist in medicine knows this, in public health, you empower women, you lift an entire population. That's the fastest track. And if you're worried about fertility issues, if you're worried about development, you have to reach the women, right? And so local government, federal, state, you have to have a synergy between them and also resources that you bring through the private sector. I'm very bullish on Nigeria. I don't care what anybody tells. I threw out all these negative statistics, but each time I go there, the place blows my mind. Because I know that if we have the right leadership and the right infrastructure and the right kinds of resources in place, we're going to do things, incredible things. So I'll leave it at that because I know the others want to ask questions.
Do we have any other comments from Dr. Kelley or Dr. Gebreyes on that comment? We're just wrapping up in our last few minutes, but any closing word? We had another comment that came from one of our virtual attendees, just praising the presentation and asking about what role China is playing in Africa in the healthcare area. Does the U.S. risk getting sidelined if we're not more proactive, and do U.S. companies need to be more aggressive to go after the big business opportunity in Africa? Dr. Gebreyes, do you want to take that one?
Okay, I can try that. Okay, thank you so much for that question. Of course, again, we're saying when we say collaborative effort, really doesn't necessarily refer to a specific country or specific setting. We all wish, the world works in a very harmonious way because the problem is common. COVID-19 is for everybody, right? So any of these global issues are common issues. Federal governments, be it the Chinese government, US government, working collaboratively will help us all as scientists. I firmly believe a more collaborative approach would be great. Unfortunately, sometimes, I don't get much into policy-related issues as we focus on science and capacity building. But for sure, the Chinese government is investing in a serious way on African healthcare system. A good example, this morning, I was in one fairly large meeting as part of Gavi-related missiles project, and during side conversation, we were discussing about the African CDC, which the genesis of it, about 10 years ago or so, less than 10 years ago, originated between African governments and the US CDC in Atlanta. However, as things evolved and we get into COVID, this highly underfunded organization did incredible job coordinating across Africa. I really commend the AU-CDC partnership. But what I want to mention for the question is the Chinese government then stepped up to the plate and is investing, I'm not exactly sure how much, but more than 100 million, setting up a very large complex of African CDC office, laboratories, and others. Africa needs those resources, and I'm sure African Union appreciates that and would need the funds, so they're working with the Chinese government. And the United States government is a strong partner to many African countries, as these efforts are universal issues. So yes, the Chinese government has lots of role. Are we sidestep? I am not sure, but definitely I can tell you, at least from Ethiopian side, and we had a meeting with the U.S. ambassador and USAID leaders here in the country just on Monday, and Ethiopian government ministers we are meeting with. There is a great interest working collaboratively and high respect to us and we all, the U.S. government body. So I think I don't necessarily share that, U.S. being sidelined rather.
So certainly opportunity. And Dr. Achebe, just a closing word.
Just 30 seconds. I know I'd like to hear Kelley speak about that. So our company, AIDE, is focused entirely on getting the United States front and center. This is the largest economy in the world. It has the best institutions in the world. It's not doing enough. So yeah, China's there. China spent $210 billion in Africa in the last 10 years. Just keep that in mind. America has the capacity, the best in terms of goodwill. If you ask an average African, what brand do you want? They want the US brand. They don't want Chinese brand, right? Let's get real. Right now, the KfW, which is the German government bank, has stepped up to support what we're doing. So we want Western brands. We want the best people from the best institutions. I have nothing against China. I'm just telling you what we're doing, and because there's a gap, and I think that gap is real, and we're not going to get where we want if we don't have the best people. Israel has joined us. Right? Sweden, we have 15 countries that are stepping up from the West. They know there's a gap. France, 2 French companies are joining. So that's my focus. Canada, that's my focus right now. The Chinese, I have no quarrel with them. Let them do what they're doing.
Thank you. And thank you to our panelists. Thank you to Al Rajwani for submitting that online question, to our virtual audience, all of you here, to Texas Biomed for putting together this Global Health Symposium. We're coming to the close of day 1 here in just a little bit, and we invite you to join us back tomorrow for our virtual and our in-person audiences. So with that, there's a closing that's coming up in here in just a few minutes. So that's our session as we look towards global health trends in 2050. Thank you again to Dr. Achebe, Dr. Kelley, and Dr. Gebreyes for joining us, and we wish you all a wonderful afternoon.